Hi, everyone. Thank you for being here. The paper that I chose to present is about a knee exoskeleton. And so I'm in the ergonomics and safety program. And so my research actually uses exoskeletons to assist people with mobility disabilities. But there are all of these occupational applications for these devices to help workers. And so this is a brand new paper. It came out in September, and it's in Science Robotics, which is kind of a really top tier journal for the work that we do in exoskeletons. And so this is really exciting to see being published in this way. And I really enjoyed reading it, and I thought it'd be a really good one to discuss at this level with this group. In Science Robotics, some of you may have noticed if you flipped through the papers, the structure of the journal is a little bit different. And one of those reasons is the methods are very engineering oriented in this journal. And so it jumps straight from the introduction into the results of the paper, because many of you probably don't really care about reading about the internal design of the exoskeleton or the controls of the exoskeleton, and you really don't need that to understand the importance and the results of the paper. So I will cover a little bit of the methods, but nothing besides what you need to understand the results, just as it's structured in this paper. So with that, I'll get started talking a little bit about their goal, which is mainly to address this problem of fatigue in workers. So fatigue increases the risk of injuries and incidents for workers, right? When you're tired, you're more likely to make mistakes or get injured. And it also decreases workers' cognitive and physical performance. And this can have a really huge long-term impact on risk of back pain, for example. And in this paper, they're looking at these lifting, lowering, carrying tasks. So the repeated lifting, lowering activities are highly associated with overexertion and lower back pain in industrial setting workers. And the quadriceps specifically as a muscle group, this is the muscles on top of your thigh, right? We all know about our quads. They're particularly susceptible to fatigue during these lifting, lowering, and carrying tasks, right? So on top of this fatigue issue, we're having workers who are having to perform these tasks where their quads are highly likely to be fatigued very quickly. And as we all know, squatting is the proper way to lift. You lift with your legs, not your back. And so squatting is the proper posture where your lumbar spine is neutral. This protects the back and the spine. We don't want lower back pain. But it is more energetically demanding, right? That's one of the reasons fatigue is such a problem. When you're squatting up and down a lot, especially carrying heavy boxes, for example, you're going to fatigue more quickly. Again, specifically fatiguing these quad muscles. So you also have this stooping method of lifting, and this is bad because you're lifting with your back and you're flexing that lumbar spine. However, it's less energetically demanding, right? You also perceive like it's easier to lift things this way because you're getting less tired and those quads aren't working as hard. So one of the things that they know is that as someone becomes fatigued, even if you know this proper squatting lifting posture, the fatigue actually causes you to start stooping instead of squatting. And so the goal of this paper is to use a powered knee exoskeleton to improve quadricep fatigue in these lifting, lowering, and carrying tasks. So exoskeletons are wearable devices that provide assistance to the users through motors and batteries. So it's a powered device, provides active assistance at the knee joint in this case. And as you can see, we have like the actuation system. That's just where all the motors are and how it's moving your leg for you. You have some other, like the R-Pine, the FSR. You don't really need those to understand this paper, but that's just based on how they're controlling the device. They're using this Breg orthosis as kind of their interfacing material. So how do you actually have someone fit a robot on their leg? The orthosis that you attach it to is really important, that it fits. And then the battery is on the back. So here we have this kind of really cool looking exoskeleton. Got a lot going on, but the idea is that it's going to assist the knee joint. And this is their whole protocol. We're going to go session by session through this paper. So we'll start with session 1. This was their day 1 activities without being fatigued. And they had each individual perform a series of tasks. So they started with stair ascent 10 times, just climb stairs 10 times, you descend stairs 10 times. You do the same for ramp ascent and ramp descent. Do the same for level walking And then you do the same for the LL task is the lifting lowering task. So just picking up a kettlebell and putting it back down 10 times. And this was to collect kind of this baseline EMG data for the quadricep muscles. They're seeing how much are your quads activating when you're doing it without the exoskeleton, and then how much do they activate when you have the exoskeleton assisting you. Right, so looking at, does it actually make you use your muscles less? And it does. The plots in this paper are kind of a little confusing, so we're going to break it down and just focus on this part of the plot. They're showing the same thing, which is that your quad effort is decreasing for all of these activities, which is great. That was the purpose of the exoskeleton. So specifically, you're looking at the difference in these blue and red lines. So the blue line is your no exoskeleton task. The red line is your with exoskeleton task. And that big decrease in that peak activation means your muscles are using less effort to perform the task. This dashed line on the plot is what the exoskeleton was doing during that exoskeleton task. So how much assistance was it providing? And this was a statistically significant decrease at all tasks except for the level walking task, which is this one right here. And that is because they describe it as being because your knees are providing less energy during that task, and thus the exoskeleton is providing you less assistance, which makes sense with some of their results here where when the exoskeleton is providing a lot of power and you need a lot of power, then you have a larger decrease when you're receiving that power from the exoskeleton instead of your own quadricep muscles. So these are the session 1 results. Basically, quad effort decreased. It's awesome. The exoskeleton is doing its job. But what happens when you're fatigued, right? Because eventually, even if you're using an exoskeleton, you're going to get fatigued at some point. It's not going to prevent you from being fatigued. So session 2.1, these next 2 sessions happened on the same day, but were kind of separate events. So session 2.1, they wanted to test what happens right after you reach that fatigued point. So it's this pre to post fatigue. They just had each subject perform the lifting and lowering task until they said they were fatigued. So they were like, oh, I can't do it anymore. Like, I am really tired. And then had them do it 10 more times. And that was the post fatigue. So those 10 repetitions were the post fatigue testing. And so then they did it without the exoskeleton. They randomized if it was you did it with the exoskeleton or without first. And then they had you rest for a while. And then they had you do it with the other condition. So switch to either doing it without or with the exoskeleton. And they also evaluated motion capture for this. So they were looking at fatigue and kind of the speed with which you do the task. And they were looking at this lean angle. So as you're fatigued and you start adapting to that stooping posture, is that improved with the exoskeleton? Which was a really interesting question. So we're again going to break down these plots a little bit, and we're actually going to look at the box and whisker plots this time. And we'll start at the top where we're actually decreasing the post-fatigue time deficit by 43%. So to break it down, these 10 repetitions that were performed after you reached the fatigued state, how long did it take you to complete those 10 repetitions? Did you complete them slower or faster than before you were fatigued, right? And during the no exoskeleton condition, it took 44% longer to complete those 10 repetitions when you were fatigued. But with the exoskeleton, it only took 1% longer to perform those 10 repetitions. So you're much faster performing that activity, even though you're fatigued, because the exoskeleton is able to help you. It's important to note as we go over this lower part, C, that they actually instructed the participants to maintain good squat form. That means something a little bit different to everyone probably, but they didn't know they were being timed when they were performing these last 10 repetitions. They were told take as long as you need to perform the activity with proper posture, right? So they were supposed to be working on not stooping. They were supposed to maintain this nice squat form. But what they actually noticed is that once you were fatigued, you do start leaning forward. And without the exoskeleton, on average, the subjects were leaning forward 10.5 degrees. So they start leaning forward a lot more than before they were fatigued. However, that lean decreases with the exoskeleton as well. So they're not stooping as much. They're able to maintain a better squat position with only 6.1 more degrees of lean with the exoskeleton. So overall, we're seeing you can perform it faster when you're fatigued with the exoskeleton, and you're maintaining a better squat position. You're not stooping as much with the exoskeleton, even after you're fatigued. So this is also really cool. They did note that with the exoskeleton unpowered, so if it's not providing assistance and you're just wearing the device, you fatigue faster. But then if you turn on the assistance, you fatigue slower. It makes sense, right? If you're adding mass and it's not doing anything, it's going to take you, you're going to get tired quicker. All right, and then the last session that they had was this continuous circuit, and this was once they were fatigued. So they had this whole pre-post fatigue session, and then right after, they had them do this whole circuit of activities, which starts with your lift and lower activity. Then you climb the stairs, you walk across the top of the circuit, go down the ramp, perform another lift and lower activity. Then you kind of walk in front of the whole circuit, and you go one way and then the other way. You go back up the ramp, you have your level walking again, back down the stairs, and then you do another lift and lower activity. And one of the main challenges in exoskeletons is, can the exoskeleton actually help when you have all of these variable activities going on, right? Because up until this point, they've mainly looked at these lift and lower activities when you're fatigued, right? So it helps you maybe lift the box and set it back down, but can you carry weight through all of these stairs and ramps that you might encounter in an industrial setting? And what they found is that it actually can provide assistance throughout and between these activities. So this plot's pretty in-depth. Basically, at this dashed line where you're transitioning from the white background to the gray line, to the gray background, that's your transition from one task to the next task. And what we're seeing is that the two solid lines, you want the blue line to be similar to the red line, and you want the two dashed lines to be similar as well. The red line is what the exoskeleton is doing, and the blue line is what your biological limb would be doing during these transition tasks. So what you're seeing is that the exoskeleton follows these transitions and provides continuous assistance between them. It's actually a really challenging task in mechanical engineering and exoskeletons. It's challenging to develop a controller that's really good for, say, stairs. But then you have a really good stairs controller, but that doesn't necessarily work for walking anymore. Now you need to switch a control method to provide different effective assistance during walking. Same goes for all these activities that they're testing in all 8 of these transition activities. And I'm not going to get into their control method here, even though it was a really cool part of their paper and is important to maybe our field of robotics and exoskeletons. But in terms of an industrial setting, the important part is that it actually can provide assistance during all of this. So someone could put it on and it actually helps them not only do the lift and lower, but you don't need to turn it off to go walk and carry the box where it needs. You can leave it on and it will keep helping you throughout all of those tasks. And then finally, for session 2.2, they performed a survey. So they had their 10 participants rate how it helped with each of these activities when they were fatigued. So that's just dividing it up, like, did it help you lift and lower? Did it help you ascend a ramp, descend a ramp, ascend stairs, descend stairs, and walk? And they gave it pretty high ratings. So that's also interesting, and had some discussion with my peers about why maybe these surveys are important. And that's because you want workers to be satisfied with the device for them to actually wear it. We'll talk a little bit more about that in a few minutes. But wrapping up with kind of their discussion of their results, the exoskeleton assistants had a significant improvement in performance and posture when performing the task, right? They had less of this trunk lean when you're fatigued. They reduced the EMG activation. You're using less muscle effort to perform the tasks. The reduced quad effort did not lead to an increase in hamstring activation. So this is important because sometimes when you start using your quads less, if the exoskeletons may be behaving in a way you don't expect, you might start engaging a different muscle to slow yourself down during an action or something like that. And so they actually decreased hamstring activation as well. 7%, non-significant, but really exciting because previously they had seen an increase in hamstring activation. And finally, thinking about that last transition plot, exoskeleton assistance was provided following all of these biological mechanisms that we use as human beings every day to transition from ramp ascent to level walking to stair descent, on and on and on. The other thing they noted is that The exoskeleton provided the most assistance during these positive work activities, for example, stair ascent, and it provided less during these negative work activities like stair descent. So that also makes sense and follows our biological activities as we would on a daily basis without an exoskeleton. They related this also to these high knee moments versus low knee moments. How much work is your knee actually doing? It's doing a lot more work when you're ascending stairs, so you need more activity, versus this level walking, which had the non-significant improvement in quad activation. You have lower knee moments during that activity. So overall, it's a really exciting paper. They had really big progress in terms of developing a way for a controller to be effective to assist people in industrial settings for all of these different activities and provide effective assistance to just decrease this quad fatigue. So there were some good strengths. Conditions were randomized, right? So when they were doing the fatigue trials, for example, they randomized whether you were fatigued without the exoskeleton first or with the exoskeleton first. And they didn't see any after effects of using the exoskeleton first. This is something that we've seen in some of our studies that we've done in lab, where if you walk with an exoskeleton for 10 minutes and say you're measuring metabolic cost, once you take that exoskeleton off and you walk without it, you'll still have a lower metabolic cost. And that kind of comes down to relearning how you're walking or retraining yourself to walk differently using these devices. So they didn't see these after effects in this study, which may have been related to just the fact that they were studying specific activities or studying fatigue specifically. But that was an important part that they did consider in this study. This reduced quad effort, not leading to hamstring activation, also really exciting. That's a big struggle in the field. And the participants, they did note, had experience with squatting movements and the exoskeleton prior. These are both big things in terms of they just had the participants, they didn't enforce the squatting posture, they had them perform it as they normally would, which accounts for differences in anatomy. I'm going to squat a little bit different than anyone else in this room would squat. So it accommodated those different movements, but seemingly it sounds like the participants still knew how to squat best for themselves. And the exoskeleton. We know in the field that the more you use an exoskeleton, the better you get at using it. And so the more you can maximize the benefits you get from using it. And so the participants had experience with the exoskeleton prior as well. They did like an adaptation, had them walk up and down, do the circuit with the exoskeleton prior to studying all of the quadricep effects. So hopefully they were appropriately adapted and trained to using the exoskeleton before actually recording data. And then finally, and this is a really exciting one for industry, but it did not require user-specific calibration. This means that that controller worked for every single person without me needing to go in and like manually tune anything, right? I don't need to change any gains. It automatically can provide the right assistance for that user, or a seemingly right assistance, or a set assistance that happened to work for everyone in this study. It's a little unclear, but I'll get into it in the weaknesses. And then finally, I just want to note, like, the results could have been better if they did personalize assistance, which they noted that subject 10, for example, was the heaviest subject and had the least benefit and the least satisfaction with the device, which is likely because the amount of assistance they were providing was not appropriate for that weight of a subject. So my first weakness is that the assistance was not specifically said to be body weight normalized. It might have been within a range that allowed some sort of adaptation in the controller, but in all the plots are really showing, okay, you hit 25 Newton meters when you're going upstairs. 25 Newton meters to me is going to feel very different to 25 Newton meters for Andy, right? And so it might not be enough for the heaviest participant, and maybe it felt like too much for the lightest participant. They also didn't give the participant weights, so we also don't know how much variation there actually was in maybe the size of these participants. They also didn't really have a discussion about why they chose to assist the knee joint. Now, from personal experience working with exoskeletons, you kind of just choose whichever robot you have that you think will do the best job. But they didn't really have a discussion about why they chose specifically the knee, right? Hip and back exoskeletons are traditionally studied for these lifting applications in industry. So supporting the lower back, having the right hip angle, which could also be associated with maybe a quadricep reduction in EMG. this is also related to, they do mention in their limitations, I think, that their quad reduction for level walking was not significant. And so in order to have a significant reduction, maybe you do need to assist the hip or the ankle, which provide more power to the gait cycle during those activities. This comment is that they use grad students as participants. This is great. We all do it, right? They're easy to access. They have to help you in your study, and then you'll help them in their study. But it leads to this really small age range. Specifically, they're 25 plus or minus 1 year of age, all 10 of these participants. That's not true for thinking about occupational workers as not aligned. It also is a different level of experience with these devices probably, and maybe different opinions on how well they performed. Thus, those survey results I really question, because as someone who has participated in other people's studies, especially if it were, say, Margaret doing the study and I'm in her lab and I want her to graduate and have a great study, I might be a little biased on giving, oh, that worked really well for me. Like, give that a 5. Oh, it could have been a 2, could have been a 3. I'll give you the 3, right? And so I think that using grad students as participants for maybe a user satisfaction survey for these devices that could be used in industry settings is probably not the right alignment for this study. And then finally, they based this good squat form and when they were fatigued just on the user's perception. So the user was just told, okay, maintain good squat form. Depended on how the user felt in their body about this squat form. Doesn't mean it was actually good squat form. It's what they perceived as good squat form. And it was also users perceived fatigue. So for someone that could have been 3 squats with the kettlebell and then they think they're fatigued. Maybe they are, maybe they're not. They didn't really have any way to double check that they actually reached a fatigued state during these activities. Overall, it was a really good paper. It's a really big step for our field of occupational exoskeletons, but there are limitations in some of these ways. And I'd love to have questions and discussion about how we can improve these exoskeletons for the future. Thank you. So these are some of the questions. I don't know if anyone else caught any other limitations for this study. Andy?
Like one big thing that we kind of run into with comparing no exo to exo conditions is like telling the subjects like the instructions are clear to them on like what to do like during these tasks.
Right.
So I just want to know, and you might have said this before, but did they give them the same exact instructions for with the exoskeleton as without the exoskeleton?
That's a great question. I think the main parts of the paper where they actually describe the instructions they're giving to the users, primarily during that fatiguing session, the pre to post fatigue. And they say that they told every participant, I'm assuming during both the exo and no exo, that they were going to perform the action until they were fatigued. When they say they're fatigued, they're going to do it 10 more times, just maintaining that good posture control. So they didn't really specifically say anything about whether the I wouldn't say it either in my paper if it was different, but they didn't specifically state that it was the same instructions for the no exoskeleton and the exoskeleton conditions.
Yeah, I can just see it as being a limitation.
For sure.
They told them, oh, use good squat form with the exoskeleton, and they didn't tell them that when they were not wearing it.
One of the things that they noted in the stair ascent specifically is that there are 3 different ways to ascend stairs. One is very like knee centered, you use your knee a lot, but you can also ascend stairs using your hip a lot or using your ankle a lot. And because we're using a knee exoskeleton and that was where the assistance was going to be, they had all of these subjects try to ascend stairs using a knee-oriented stair ascent technique. I don't really know what those different techniques actually are. I would need more instruction than that on how to actually use my knee more if I'm using my ankle more. But they did specifically say that because once you have the exoskeleton assistance, participants would likely start transitioning to a more knee-centered approach, right? If you have the assistance at the knee, you'll start using your knee more probably to leverage that assistance. They did say that during all the conditions they tried to have the participants use their knee to climb stairs.
I'm gonna ask, what was the motivation, do you think? Why do you think they didn't use a more standardized approach to assess fatigue. There are like a couple ways I could think of right now that would be like, even just like a little bit more structured than.
Right. I think they did mention it in their discussion that having the user define their fatigue is a technique used in physical therapy sometimes of like when you feel like you can't complete the task anymore, you're fatigued. And I'm pretty sure that's just how they justified it was probably what was easiest for them, right? Is to just say like, all right, when you feel like that's your last squat, then you're fatigued, just let us know when. And though I do think using something like your EMG, because you can see when you start transitioning from using maybe if that quad's fatigued, you're going to start using it less, and that maximum voluntary contraction of that muscle is going to be lower. Honestly, a really easy way to check.
That's the easy shit.
Mm-hmm.
How might the age of the participants being 25 plus or minus 1 not be a weakness?
I think.
What do you guys, I mean, you don't have to be the only, what do you,
Okay.
because others can answer that question. But how might it not be a weakness?
It could be a strength in that maybe very physically demanding jobs like warehouse workers, and somewhere like maybe is what leads a little bit younger.
Yeah.
To mid-20s.
That's true.
What if you had,
Representative.
what if you had a person who was 60, a person who was 50, a person who was 40, a person who was 30, and a person who was 20?
The
How
person,
would you draw the comparison then?
well, the person who likely needs, I know it depends. The person who might need the most assistance in order to see a reduction in the quadriceps is probably actually that youngest person, right? They have the strongest EMGs or the strongest muscles are going to get fatigued less quickly, need more assistance, or like need to continue doing the activity for longer. So it might have been almost like a worst case scenario test in some circumstances.
So the reason I said that is because you almost, it's not quite a constant, but you're almost saying I'm holding my participants somewhat constant.
Mhm.
Because if you had 5 people who were 50 and 5 people who were
Right.
25, then you'd have really 2 groups. You know?
Yeah,
Because those are going to be 2 very different, people, sets of people. So
Exactly.
in terms of wear and tear, in terms of, muscle fatigue and so forth. The other thing is, it's absolutely a weakness if they're saying, and this means you should use this in your workplace.
right.
Totally a weakness. But as long as they're not making that trying to make that kind of inference, if they're just trying to say, does the exoskeleton make muscles work better or
Right.
less doing these activities, then holding that constant is actually kind of good.
Yeah, that's great insight.
As long you think about the limit, it becomes a limitation when you try to make inferences that it can't do.
Mm-hmm.
And I think they actually did pretty good about not trying to infer
I agree.
that it was related, that it would, any practical inferences. They were just kind of saying, okay, is this making a difference with using the exoskeleton versus not? So I'm not saying
Yeah.
it's not a limitation. I'm just saying
No, that's a great perspective on it.
limitation might be framed,
Yeah.
right? Because when someone's going to point that out, and you did,
Mm-hmm.
but how would you frame it in a way that
How can you make that a positive
this
thing?
is actually not a concern for
Right.
what we're doing?
And I think that's very fair too, especially because we do have this problem kind of in the field of exoskeletons where we're at the point where we're doing all this research that's showing maybe it could work in an occupational setting. Maybe it can help for these tasks in these ways. And this is a big step in terms of it's assisting many tasks instead of just one task now.
Yep.
But we're still pretty far from saying, oh, we're going to have workers wear this and we're going to test it in an occupational setting right now. That's still pretty far down the road, I think. And especially if you think about maybe that first picture of what the exoskeleton looked like, all those wires, I mean, and you have a backpack on and it's all down your leg. A lot of those things might be very hard to implement at this stage in an actual occupational setting. So it's a great point. I think that is one of the things that's actually really nice about this study too, though. Yeah.
Jesse online had a question
Of
that I think
course.
we're just addressing a little bit about whether you think that exoskeletons tested in a controlled lab setting will perform the same as in a real occupational setting, and you just sort of answered that.
Yeah.
And so I'll elaborate on that a little bit. What are some of the hurdles from where the technology is right now and the testing is right now
Mhm.
to actually get to the point to where it could be tested in an actual occupational setting?
Yeah, I think there are quite a few to consider. One being this wasn't a lab environment. And the reason I actually didn't have that as a limitation, whereas I have when I presented an exoskeleton study in the spring, is that they actually they presented more of these activities and we're talking about considering these variable terrains. And I think that that was a really important step, is we need an exoskeleton to be able to run over all of these different activities. However, if we're looking at what's keeping it from being implemented in like an actual occupational environment, it needs to also be able to run autonomously, right? Because same in our lab, someone was probably watching the controls on the laptop connected to the device, right? And no one's going to be running an exoskeleton from a laptop in an occupational setting. It needs to be able to turn it on and it just knows what to do. And while I think the controller could work that way, they actually don't specifically implement it that way in this paper. And so that's one thing where in order, like if you're going to require connection to say a laptop in order to use the device, it's not going to work in an occupational setting.
Anything else? We're at time, but let's make a couple more.
So two questions.
Yeah.
First one is the number one injury we're trying to reduce is what, and does this device do so? How? Question.
Yeah, the main thing they were considering is this low back pain, right? Where I think it's the risk of low back pain because when you're fatiguing these quadriceps day after day and you start adapting the stooping posture for lifting, you're no longer protecting that lower back and you're increasing your risk of back pain. And so if we can keep the quadriceps from fatiguing as fast, or if we can provide that assistance to maintain a squatting posture when fatigued, then we're less likely to have this increased risk of lower back pain.
For any epidemiological evidence to support what you said, because that's the hypothesis.
I think there were actually some papers that were cited in the introduction about like lifting and lowering tasks being like associated with overexertion and lower back pain, and like the quadriceps being pretty likely to fatigue.
Yeah, but the point is, there is a nice significant literature saying quadriceps fatigue is
associated with lower back pain directly.
Exactly. And if you ultimately are able to lift more, you could have higher frequency issues, which would then actually increase your low back pain risk, not decrease, right? Because this is not really designed for the spine; it's designed for the lower extremities. So
exactly.
That's a key limitation. The other thing is, I wanted to make sure people are aware of because it gets messed up all the time. The cartoon figures here are not the same figures you had earlier in the presentation.
They're not.
Very different.
Yeah.
And some of the residents especially should know this and be able to get, because I went over this with them. But what is the problem with the prior lifting figures versus these? And this has to do with also their what they did in this study is they had, in the interest of time, I won't go Socratic. I'll just have to give you didactic info. They're basically lifting a kettlebell, okay, a dumbbell. The small object is not lifting. The lifting industry is a much larger object, not small compact things. Small compact things you can easily get between your legs, and you should be lifting with your legs and not your back. Large objects, if you do that, you should all have experience with this, with your revised Nash lifting equation and stuff like that. Your horizontal moment arm is far too long, and you're going to have lower compressive forces on your back if you lift with your back and not your knees. The cartoon figures earlier, if you flip way back to the presentation, show you object you cannot get between your legs. Okay. The green check should be on the right, not the left.
Interesting.
Yeah. At least based on if you believe the compressive forces in the spine are related to and not, for which there is actually some epidemiological evidence. So this gets mistaught all the time and mucked up. The short answer is on the right. Go get somebody else to help you with it.
That's really interesting. Well, thank you. Now I know how to lift boxes.
About this now.
Hear me okay?
Awesome.
All right. My name is Troy Hancock. I'm one of the occupational medicine residents. I'm excited to be here today. Before I get started, the question I have for you is, which country is the happiest? Sweden, Finland, Denmark, US?
No.
US not in the top 20. So we're correct, Finland. The question I have is why Finland is so happy. Right? What makes the Finns the happiest people? Study after study shows that they're the happiest. Right? I think it is associated with saunas. Right? So there's about 5.5 million Finns, and there's about 2 million saunas in their country. So it's about a 3-to-1 ratio of saunas to person. So the average Finnish person takes 4 saunas a week. So why is that interesting? Well, some interesting things about the Finns are their all-cause mortality is decreased compared to other populations. Don't quote me on this because I'm just saying right? So their all-cause mortality is decreased, their sudden cardiac death events is decreased. The question is why? Can't be that they're happier because their family circle and their social network is good and their, good work-life balance. The only thing I can think of is because of saunas. It has to be the saunas, right? So the study that we're looking at is looking directly into, is there a relationship between infrared saunas as the exercise method? Because everybody knows that exercise is good, right? Habitual exercising shows benefits for everything. Saunas have that same relationship, and that's what they're asking about. Now, this study is very interesting, and we're going to go through it step by step. And when I did the study research and it said randomized controlled, I was happy. And then it said crossover, I was like, win-win, right? It's all the buzzwords. So its objective is the short-term thermal and cardiovascular responses in women, right? Particularly in women. How do they compare to moderate exercise? The study design, as we talked about, was as a randomized controlled study. What they had 3 interventions: a control group, an exercise group, and an infrared sauna group. All visits were conducted. Each control session, each intervention session happened 48 hours apart. Now there was a big difference between when that second session happened, but it was at least 48 hours apart. Everyone completed their first trial, the first control session, and then they were randomly assigned to go to a different treatment, another interventional group. And if you guys were alive in 2020, you would know that something weird happened. COVID jacked up everything, and it did the same with the study, ended the study short. All right. I was hoping Dr. Thies was here. This is a shout out. Anybody wants to know what a crossover study looks like, right? All right. So they were very stringent on their participant selection. They found a lot of research articles about men, particularly with chronic medical conditions, and men that exercise a lot, like athletes. And so they really wanted to broaden the scope of who they were looking at. So they wanted women, not just any women. They wanted premenopausal, non-pregnant, healthy women. And I thought this was funny. They didn't like They didn't like the Finns because the Finns weren't allowed to participate because you could not have done a sauna treatment within the last 6 months. So no chronic conditions, no medications, birth control pills were okay, and normal BMI. BMI being judged at above 18 and below 30 is what they said, I believe. I thought it was interesting. They specifically said here, no chronic medical conditions, but then they made the exclusion criteria Raynaud's and AFib, and that has to do with the way they tested the subjects. All right, so 3 groups. The first group, the control group, was the first visit for everybody. You showed up, you did a questionnaire, answered some questions, they took your measurements. Then the control was you sit in a nice 77-degree room and just hang out for 15 minutes. And then you take a break from doing that. Then you go back in and do it again. They check your measurements, right? And so at each break is when they take the measurements, and then post for recovery, they did the same thing. The next group is the exercise intervention group. They had the same format. You come in, take your vitals, your questionnaire, and then treatment, which was 15 minutes on a standardized bicycle, moderate effort, which that was determined to be 50 to 70% of your maximal heart rate being 220 minus your age. And then they measured you post as well. The infrared sauna group, same kind of format, 3 15-minute sessions. You're sitting in a 60 degrees. Infrared sauna is 60 degrees, that's like 140. It's a little lower than your other typical saunas you might be checked with, but these infrared saunas are about 140. Relative humidity was around 20% or less than 20%. Did your measures, did a cool down, and they did the corresponding measurements of your vital signs. Outcomes that were measured, whole bunch of them. They looked at a lot of different variables. And we'll go through each of these really quick. Words. All this is saying that they use high quality medical grade specific stuff in the article, tell you exactly what they use so you can see it. But they went to, plus or minus 0.1 kilos for weight. They were very good, and it was standardized to use the same instruments through everybody. Some things that maybe you might not be familiar with, urine specific gravity, what that was is that it's a urine dipstick that they use, and that's what they use to assess your hydration status. If you're dehydrated, it might mess with your measurements, and so they wanted to make sure that everybody was hydrated accordingly. Tympanic temperature, it's in your ear, right? They checked those measurements, skin temperatures. They specifically looked at the forehead, the back, and under the arms. That was infrared, no touch, kind of just squeeze and look at it. Respiratory rate, they did the old-fashioned way, is just counting. They stood there and looked at you and counted how many times you breathe. Blood pressure. To me, this is the vital sign, but they separated it out. So everybody knows the blood pressure machine you've all had taken. That was the standard thing that you do. Mean arterial pressure. What they're looking at for these is they want to know, they're trying to judge the arterial wall stiffness or how rigid it is, and that's what they're trying to figure out using these next couple of things. And the mean arterial pressure is just a equation they use to kind of estimate that. Normal humans, happy, healthy, around 70 to 100 is where you are. Pulse wave analysis is very similar to your blood pressure machine, except instead of hooking into the wall, you're hooking into a computer, and they're checking your brachial pulse. So what they do is they take your blood pressure, and the cuff deflates about 50%, and then it just sits there and analyzes. And it does some calculations based on your brachial artery, and they can give you some cool information about your overall, the rigidity of your artery. This is pretty high-tech stuff. It used to be invasive where you had to, but there's a lot of good work going towards estimating that arterial wall stiffness or rigidity. And they were sitting there. For that, heart rate variability, this is pretty cool stuff too. It's up and coming. Everybody's talking about heart rate variability. For everyone here, the higher your heart rate variability, the better things are. And that means that you can adapt to situations and your tolerance. So that's what the high is good, low, not as good, right? It's a marker for stress levels, recovery, and autonomic health. Just sitting here, your heart is varying, like mine. Stress the situation, maybe not so good, right? But if you're sleeping, it changes. If you're breathing, whatever it is, this variability changes, and they can measure that. And what they're doing is your heart, they say it's like a pacemaker, right? So it's just regular. It's never like that, right? It changes with everything, and that's what they're measuring, the R to R intervals between that. All right. What they do, so 24 hours prior to coming into for the study, they said, hey, don't put any lotions or wear topical things on your hands. Have dinner, fast, come in fasting, and we're gonna do we're going to do the entire session with you fasting. Takes about 3 hours. And then the outcomes are measured pre, 15 minutes and on, and then post. So that gives you T4. And hydrate, hydrate, hydrate. Sample size. This to me, so I picked this article because I was really trying to I want to improve my stats. And so I was really looking at this stuff, right? And so I see a sample size. The power analysis says that you only need 9 people to make this successful, right? That's what your stats say. I'm like, interesting. So, but based on the measures that they set ahead of time with your alpha level and your beta level, they determined that 9 participants was all they needed. So they did a lot of cool stuff to measure if there's normal distribution, what the variance and how all these many different variables interact with each other, with the dependent ones, with the independent ones, and how they interact with the groups. And I learned a lot, and I'm really excited that today at Biostats, we're going to start learning some of these other things. So it's kind of a precursor to set me up for success. And then this post hoc, I really put this word in here so I could say bonforoni. But it's a way to test once you have statistical significance that you're noted in these variables, you can go in there and do this test, and it helps to decrease the likelihood of type 1 errors in these whole bunch of variables between these groups. So, all right, so what do we have? They started out, they put advertising out, they got 37 women that said they'll do it because of different reasons. They all fell out, and they got 10, which math is difficult, but 10 is more than 9, so they met their assumptions, right? There were no dropouts in studies. We talked about the environmental settings that they tested in, and hydration status between the 2 groups was great. So to recap, 10 of them showed up, did the first thing together, 5 and 5 went to randomized groups, right? So what do we find out? The thermal responses, checking your tympanic membrane, showed that the sauna, there was significant change. That's what this first line says. They noted change with the math that they did. The Wilks Lambda showed that there was some statistical significance, and they wanted more information. And the post hoc analysis using the Bonferroni helps to elucidate where were the differences. So kind of as expected, the sauna group, the tympanic membranes were hotter, more so than the exercise, and the exercise beat control. So there was a difference. Sauna wins out on this one. Next one, skin temperatures. This is kind of interesting, I thought. Yep, we noticed that there was a difference. Let's look at it. The control group skin temperature, mainly only on the back, was warmer, or excuse me, was cooler than the back. Than the sauna group, sorry, right? So the control group, they were warmer on the back, which I thought was weird. You think you're exercising, you're in the sauna, those backs are going to be warmer, but it's not, right? And the same thing that was showed. You have a little bit warmer on the sauna group than exercise, but the control group wins out on this one. Respiratory response. To me, this was the easiest one to predict, I would think, that you're out there riding a bike at 70% your max, you're gonna be breathing a little bit more, I would think. What I thought was interesting, though, was a sauna versus control. There was really no difference, right? Sauna versus exercise, the exercise won, and the control exercise won out again. All right. Cardiovascular response. This is where we get into some it's going to point us to where we need to go. There was some changes, but it was all with exercise versus control. The exercise group had bigger variations in their heart rate than compared to the other groups. And for systolic blood pressure, the only trend that they saw was in the systolic portion, not the diastolic. And they found a difference, and then they post testing, and they didn't see one. So there's no impact on blood pressure, all right. So pulse wave analysis, this augmentation index 75 means that they did some math stuff and corrected and compared to the normal heart rate of at 75 beats per minute, because there's a lot of variability in heart rate. And so they corrected it using a 75. And again, post hoc analysis, they showed some changes versus the two ways they did it, using the central augmented pressure versus the calculation from the pulse wave. Again, they showed some differences, went to look for no differences in the pulse wave analysis between exercise and sauna or control. Heart rate variability, where we're expecting to see some differences, because there's really not. They did not see the differences in heart rate variability. Still don't know why the Finns are so happy, right? Yeah. Again, this just shows that there was no difference in pre or post heart rate variability changes. Conclusion: if you want the benefits of exercise, you're going to have to exercise. and that's pretty much it. There's also there is some significant differences. I mean, work needs to be done, because it points that the sauna works through a thermoregulatory effort as opposed to a cardiorespiratory effort. And there's lots of articles that are out there, if you do a search for it, that show the benefits of infrared or just normal sauna in chronic medical conditions, in that. Not so much in the ACOM guidelines. It's all kind of a wash, but there's stuff out there that further research needs to be done, right? So strengths and weaknesses, this is what I came up with. Obvious strengths of the randomized control study, right? That's what we need. We need more of these if we're going to tease out the differences. This is where you get it. I like that there were multiple outcomes. They measured lots of different things, which I thought was a strength of the article. The 48-hour washout period, I think, was really good, and it helped. It helped with I did the ACOM guard article checklist to see if how well it's set up, and I was like, blindness. Can you set up for blindness in a randomized control study? And you really can't. But the ways that they try to mitigate that, one of them is having a good washout period, right? And the other one is trying to limit with that Bonferroni and measuring out. Those are things you can try to do it, but you really can't. Relevant. I thought this is really relevant. We need to. There's people out there that are not going to be able to exercise, and they can't do this because they have things, and it's a vicious cycle. Exercise, but I can't because I hurt. I do it, and it's just a vicious cycle. So if we can find ways that they can better their lives without hurting themselves, by get them motivated, get them moving, this is good. And if this is on women, lots of studies out there about the guys, lots of studies out there about elite athletes, and this, I think, piled on to say, hey, this is a randomized control study. There didn't show difference in some things, but it points to this other one. So I thought it was a pretty good small sample size. Is that a weakness? The stats said no. You needed 9. We got 10. I don't know. The study took 8 months, right? To me, that introduces some biases. Maybe if this happened in Australia, and you're going, say it happened here, January is different than August. Right, so you might say all these studies happened. And the other one's varying washout period. Some people waited 42 days between their different trials, so there was little difference. Circadian bias, did in the mornings, everything in the morning. Some people like doing stuff in the morning, some people don't. Is there some kind of bias there? Only measured 5 minutes post. I think the benefits of some sauna might be more cumulative. So not 5 minutes post, you might see it, but how about an hour later? Maybe that was a weakness. There was only one researcher that did all the things, but she got paid really well. I'm told. I don't know. But there's unintended biases for that. Yeah. So serious, what do you guys think about that sample size? Anybody have any thoughts on that? I mean, epidemiologic studies, you'd want 100 people, but the stats say you need 10. Who wins out?
mean, for an experimental study, you only need the sample required to detect an effect size of the estimated magnitude. So I was trained in a discipline called applied behavior analysis, where for many decades, the tradition was only to care about effects that were visible on a line graph. So they had to be large enough that it was an obvious change. And so if you have a large effect, you don't need a big sample to detect it. So, and I know epidemiologists, I've spent my whole career dealing with this kind of critique, which is why I'm commenting on it. When somebody just says, oh, 50 people, that's a small sample. Well, it's only small if you're trying to use it for a purpose that is different than intended. If it's an experimental study and you're trying to detect an effect that's like a whole standard deviation, it's probably more than large enough. But sorry, there was another person down here.
The other thing is because they're comparing like within subject, I think that really reduces the number of people you need, where you're like every subject is doing both conditions and then you're only looking for a change in how I interpreted it.
Effect of this is, what is the follow-up time here?
Excuse me?
What is the follow-up time? You intervene. How long is the follow-up?
5 minutes.
Yeah.
So this is, we wouldn't even call this a randomized controlled trial. We just say it's an experimental study. And if you want to find out if there's any kind of enduring effect, the minimum you should have done is measured it before your 2 days or 3 days down the road intervention to see if there was any enduring effect.
Love it. Love it.
Conceptual question I have is, do you think the patients are using infrared sauna versus a traditional sauna was? And do you think that would have changed their results?
A lot of the other articles in there looked at the other types of saunas, which are higher temperatures, and they did the higher temperatures on those groups we were talking about, the sick people with known history and stuff, and that's where they saw benefits, right? Is they saw those, so they were trying to recreate it. The infrared saunas I think are more popular, and people can have them in their homes a little easier, so there might be a correlation that way. But they did not go into that way. But the availability of the sauna would also be one.
The effects could not only just be temperature dependent, because they're using two different methods. You know, one is heating the air and one is using infrared. So
yeah, infrared, and they also looked at submersive. They all the other. There were lots of good articles. There were lots of articles. There's lots of articles about not infrared, but other types. And they looked at that, and that's where they saw those benefits. And they think that they saw those benefits. They did not see the benefits here because you have healthy women who don't have any chronic medical conditions. So the male population with chronic, they're going to have those stiffer. You might see some with those lower, sir.
Yeah, I'm old, so when you introduced the subject, I recoiled when you said Finland was the happiest country, because I remember they had the highest suicide rate in the world. Really, it stayed that way till the end of the 20th century. And right now, they have the 9th highest rate of depression in the world. And I looked up the happiness index, and the happiness index is not whether you're happy, but whether you feel your life is in balance. So I don't know. Maybe you oversold us a little.
I don't know. All I'm saying is you're gonna go look on Amazon and buy a sauna.
Okay.
Invite me over.
At that point, the language choices are extremely important, because words mean something different in different languages. And it's even true within the US, where we've got so many cultures. So we will never be the best at this sort of stuff because we've got all these different people. It's our strength, The other thing I'll mention is if you ever drive around Finland, which I've heard, every single person is on a lake, and they all have this like wooden teepee, and the wooden teepee is not right next to the lake. So you can see right away what goes on all winter, which also gets into, you gotta watch what time they're doing their study, because they have different results depending on what time of the year it is, because it's awfully dark there in the winter.
Matt?
Good job, Troy. Really interesting topic. The question that was going through my mind as you're presenting it has to do with applicability, the results. And it sounded like a lot of the results didn't show there was benefit or they weren't significant, but even if they had, I still have questions about it because the measures they were using, we don't really know that it's heart rate, and skin temperature, and respiration, and heart rate variability that give you the benefits from exercise, right? So those are just surrogates. Had they said, wow, sauna treatments give you just good or better benefits in these categories, for me, I'd still be like, okay, is that really why we exercise? Like to get our skin temperature up? So that'd be my comment on it. That's not something you have to address, but if anyone else has any sort of leanings that way.
And especially short term.
Yeah.
The same thing, like you're only changing it for those 5 minutes, and like exercise has cumulative benefits, and you probably saw them too.
True, you have a
Which
heart
is
rate
a-
variability that lasts beyond the initial exercise period, right?
Also, seems like they're focusing on the cardiovascular benefits, but like, I don't think a sauna is gonna increase your bone density.
Or your mental health, or your, like your emotional well-being type of stuff too. That's true. Could be.
How about go exercise and then jump in a sauna? Like, right? Like smoking a. Anyways, that's all I got.
All right, see everyone next week.